Hi everyone, let us start with the second chapter of Rapid Revision General Pathology, that is inflammation. The first thing that you have to know is the classification, which is done on the basis of the fluid type. The most common one that you encounter is going to be the catarrhal inflammation, which I'm sure all of you have experienced, and that is the common cold. So whenever you have common cold and you have a running nose, what secretion comes out? It's always a mixture of mucus and water. That is the most common fluid that we encounter. Another one that I'm sure that all of you have seen is purulent inflammation. What does the word purulent means? It means pus. And where do you see a pus? You always see it in something like a boil or an abscess. The next two types of inflammations are serous and fibrinous inflammations. The word serous means watery, means if someone has serous pleural effusion, this means the pleural cavity has watery fluid filled in it. If I say fibrinous pleural effusion, the word fibrin refers to thready, that you can actually stretch the fluid. The fluid is going to leave threads and strings. And I'll give you an example. In rheumatic heart disease and cardiology, you study that the pericardium shows you serofibrinous pericarditis, means the fluid in the pericardium is little bit watery, sero, and little bit thready. And because it is thready, like it can stretch like butter. So they say that pericardium are like two pieces of bread and that fibrin in between is like butter. So that is why this is defined as the bread and butter appearance that you see in the rheumatic heart disease. This was the first type of classification based on the fluid type. The second type of classification is based on duration, and that is going to be acute inflammation and chronic inflammation. I think the meanings everyone knows. Acute inflammation starts early, chronic inflammation starts late. They ask you, if you get a blood report done, what will you see? In acute inflammation, we will always see that there is an increase in neutrophils that is seen. And in chronic inflammation, we see there is an increase in lymphocytes, macrophages, and plasma cells, out of which the most important cell that you see for chronic inflammation is macrophages. Examiner doesn't ask you rules, he asks you exceptions always. So remember, all the acute inflammations are going to show you neutrophils. However, typhoid is an acute inflammation, but it does not show you neutrophils. On the other hand, it tends to show you relative lymphocytosis. So if you look a little carefully, it is an acute inflammation, but it's not showing me cells of acute inflammation. It's showing me cells which are opposite. It is showing me cells of chronic inflammation. Similarly, all chronic inflammations are supposed to show me lymphocyte, macrophage, plasma cell. However, chronic pseudomonas, the word says chronic, but it doesn't show you these cells. It in turn shows you a cross connection. So pseudomonas is going to show you the presence of neutrophils. So this is again a cross connection, that it is a chronic inflammation, but it is showing me cells of acute inflammation. So all acute inflammations except typhoid, all chronic inflammations except chronic pseudomonas. This is what you get in the exam. Once you're done with the classification, the first part of the chapter is going to be acute inflammation. And please note, acute inflammation occurs in two places: blood vessels and cells. There are 4 blood vessel events. There are 7 cellular events that you have to know. Let us start one by one. What all is happening in the blood vessels? So please note, in the blood vessels, number one thing that you can encounter is going to be vasoconstriction. As all of you can understand, what do you mean? The blood vessels are going to shut off. When I say the blood vessels are going to shut off, do you think I can keep my blood vessels shut for very, very long? Of course not. This is only going to be for a few seconds. But yes, ma'am, we do understand this is the very first event of inflammation that you are teaching us. But why has it happened? Why have the blood vessels shut off? This is a kind of a reflex, which means that right now you got hurt, God forbid, and you start bleeding. What do you think your blood vessels should do as a reflex? Your blood vessels should shut off so that no more bleeding can happen. So for a few seconds, they will shut off. And after that, they are once again going to open up. So there is going to be a vasodilation. As all of you can see, the blood vessel has dilated. Who dilates the blood vessel? It is because of 2 mediators, that is going to be histamine and serotonin. So histamine and serotonin are the 2 brothers which always work together, and they increase the blood vessel diameter, vasodilation. Now coming the third point, increased vascular permeability, which means that if this is a blood vessel, everything is going to come out of a blood vessel. What all will that include? Cells will come out. Water, ma'am, plasma will come out. Plasma will have a lot of protein, so they will also come out. So that means all these things together, cells, plasma, proteins, what are they known as? They are together known as exudate. All these things are going to now come out of the blood vessel, increased vascular permeability. Okay, just imagine all the water has come out. What do you think the RBC concentration must have become over here? Ma'am, all the water has gone out. This means RBCs are very, very concentrated. If the RBCs are very, very concentrated, can I say that the blood has become very thick or the blood has become very viscous? And if the blood will become viscous, the blood flow will slow down. And what is that slowing of blood flow known as? Step number 4, that is stasis. Because the RBCs are so concentrated, now the blood is moving very slowly. These are the 4 events: vasoconstriction, then vasodilation, then increased vascular permeability, and then stasis. Out of these, if you get a question which is the most important hallmark event of acute inflammation, it is going to be increased vascular permeability. So exactly what you have to read in detail. How does the blood vessel become so permeable? So if someone asks you, what are the different mechanisms based on which the blood vessel is becoming permeable? The first one and the most important and the most common one is going to be endothelial cell contraction or retraction. Sounds a little difficult. I'll simplify it. There are endothelial cell gaps formed, which means if these are two endothelial cells, they will separate. Either they will separate by contraction or they will separate by retraction. Either ways, there will be a gap created. So for example, if I label it like this, I have made a blood vessel for you. I think everyone knows the lining of a blood vessel is endothelial cell. And just a quick note, all endothelial cells are CD34 positive. I am saying the endothelial cells are going to contract. So what will form over here? A gap will form over here, and ma'am, if a gap is forming, then everything is going to flow out. Which are the two mediators that are going to help in this? It's always the cousin brothers which come to the rescue. That is going to be histamine and serotonin. The question that they ask you is that is this contraction, retraction, gap formation, is this going to occur very quickly or very late? So remember, histamine is a hero, and hero is going to act within seconds and is going to become a blockbuster, give a blockbuster movie within seconds. Everyone is going to love his acting. So histamine works very, very quickly. The timing is going to be immediate, means it starts very quickly, and then as quickly it is also going to fall off. So anyone who becomes famous overnight is also going to crash overnight if he doesn't work hard. Same way, histamine is that hero. He starts working very, very quickly, but then after some time he stops working also very quickly. So it is an immediate transient response. Now we come to the second mechanism. What other mechanisms can be there? So there can be direct endothelial injury, which means what? Someone is trying to damage these endothelial cells from outside, or someone is trying to damage the endothelial cells from inside. Let's take an example. Everyone, if you've gone to the beach and you spent say 6 hours or 8 hours at the beach, you might have suffered from something known as a sunburn. So we all know that sunburn never ever starts off within seconds. Sunburn happens when you spend 8 to 10 hours under the sun, right, on the beach. So remember, sunburn will always be delayed. So if someone asks you, okay, sunburn has come and sunburn from outside the sun has damaged your blood vessels, what kind of a response is it? So remember, the timing is going to be delayed, prolonged response. And you need to kind of understand that why is this delayed and prolonged? Because just imagine, does sunburn start quickly? No, ma'am. Sunburn starts very, very late. And once you get a sunburn, do you recover within seconds? No. The recovery also, skin peels, ma'am. Recovery also takes very, very long. So starting is very late, ending is very late. Delayed, prolonged response. How students have learnt it as that when we are talking about sunbathing, with sunbathing we have learnt Deepika Padukone. Okay, with sunbathing we have learnt Deepika Padukone, that is delayed, prolonged response. Now let's come to something from inside is trying to damage the cells, and that is going to be sepsis. Sepsis, we all know, lot of bacteria, a lot of infection. From inside they come and they damage the cells. So what kind of response do you think sepsis is going to show? Just imagine sepsis, ma'am, it's so severe that the response, I mean the damage will start immediately. So the damage that I will get in sepsis is going to be immediate. But tell me the treatment. Can sepsis be treated within seconds or minutes? No. Antibiotics go on for very, very long. The recovery is going to take a very, very long time. So this kind of a response is the immediate sustained response. Means for this you will learn that when I'm talking about sepsis, the response is going to be immediate and sustained. Remember, for sunburn you had to think of delayed, prolonged, Deepika Padukone. With sepsis you have to think of cyst, that is immediate and sustained response. After this, the third and the fourth mechanisms are almost very similar of increased vascular permeability. The third one is going to be transcytosis. What does trans means? Trans means transport and cyto means cell. So this time, whatever will travel out will transport through the cell. Ma'am, are you making any, did you cause endothelial contraction, retraction? Did you make any gap? No. I'm saying, like, if usually if someone has to walk out, he has to open the door. I'm not opening the door. I'm saying become a superhero and just barge through the door, break the door and move out. CID, just break the door and move out. How can the cells break the door and move out? Ma'am, practically not possible. Someone has moved out without opening the door means kuch underground tunnel someone has made. So there must be some underground thing that you have made on the side. And what is that underground thing known as? That is known as the VV organelle. Please remember, for those who want to know the full form, it is a vesiculovacuolar organelle that has been created, and via this tiny little tunnel the cells are moving out. Is that okay? Coming to the last mechanism, angiogenesis. We all know what is angiogenesis. Angiogenesis means new blood vessel formation. I have made a new blood vessel over here. Anything which is new in the body is going to be very, very immature. Of course, it's going to be baby. So when I say baby, do you know immature blood vessels have something in them that is going to be endothelial gaps. By default, they have gaps. Means, ma'am, everything is by default going to move out of them. So we call them leaky channels. We call them leaky blood vessels. And automatically everything will move out. As they will mature, these gaps will fill up. But right now when they are new, they are immature, there are gaps present. So again, everything will become permeable. Do you know for transcytosis and for angiogenesis, because in both places, either here you are making a new blood vessel or here you are making a hidden tunnel. Whenever you are making new things, you have two mediators. One is going to be VEGF. Whenever you need a growth factor, it is always VEGF for the blood vessel. And the second one, of course, is our hero, that is histamine. You are done with all the vascular events. As I had told you, we were studying the mechanisms of increased vascular permeability. They have been done. All the 4 vascular events are over. I had told you after that we will move on to the 7 cellular events. And there is a mnemonic for the 7 cellular events, and that goes by the name of MRAT-COP. So we are going to study MRAT-COP one by one. Then we will come back to this slide and make a summary. The first step, let me make a blood vessel again. And I think everyone knows that in a blood vessel, this lining that I've made is going to be the endothelial cell, CD34 positive. Now I'm saying, look at the cells. Where are the cells flowing? Now in acute inflammation, the cells are flowing here. Ma'am, this means normally they don't flow here. No. Normally cells are going to be at the center of the blood vessel. And you get a question in physiology, which is the centermost cell that you have in a blood vessel? The centermost cell is going to be a red blood cell, which tends to flow right in the center. But I'm saying, ma'am, here you're not talking about normal. Here you're talking about acute inflammation. So that means here you will say that, oh, the cells have come to the margin. Can we all see? These are white blood cells and they have come to the margin. Okay, after coming to the margin, just imagine a football. They are going to roll. Like this, they will start rolling. So what is step number 2 going to be? Step number 2 is going to be rolling, and just not rolling, like they will roll from here. They will attach for 1 or 2 seconds. Again, they will roll. They will attach for 1 or 2 seconds. Again, they will roll. So this is going to be rolling and weak adhesion that is going to be taking place. So I have done step number 1, that is coming to the margin. Step number 2 is going to be rolling and weak adhesion. But do you know who causes this rolling and weak adhesion? Ma'am, to stick somewhere, you will always need some Fevicol. And rolling like a football. Football doesn't roll on its own. You have to kick a football, right? So who is kicking the cells over here? That kicking the cells is going to be caused by selectins. So please remember, rolling is caused by selectins, and selectins we have learnt as English Premier League. Yes, so English Premier League tells me there are 3 types of selectins: E-selectin, P-selectin, L-selectin. So English Premier League. And please note, where are they present? So what have I done? Over here, I have made a leukocyte. A leukocyte, I can also call it as a WBC. And over here, I have made an endothelial cell. Why? Because this is the leukocyte and this is the endothelial cell. So I've just drawn one combination on the next page. Do you know where L-selectin is present? The word L tells me that L-selectin will be present on the leukocyte. So I mark it over here. Where will E-selectin be present? The alphabet tells me that it will be present on the endothelial cell. So I'm going to mark it over here. Where is P-selectin present? The way I pronounce P, it has 2 sounds to it. Number 1, it is present on the platelets, and number 2, it is present on P. So E means it's present on the endothelial cells. So I can again make the P selectin over here. Simple. Which is the only selectin on the leukocyte? It is L-selectin. The P and the E selectins are present on the endothelial cells. They are present here, okay, but what do they bind to? So remember, the P and the E selectin are going to bind to something known as sialyl Lewis X. So the P and E selectin were all the endothelial cell. They bind to sialyl Lewis X on the leukocyte. So repeating, P and E selectin bind to sialyl Lewis X. Whereas the L-selectin that is present on the leukocyte, what will that bind to? That is going to bind to, that has many names. Either you can call it glycam, or you can call it madcam, or you can call it CD34. They all mean the same. Let's repeat. What does L-selectin bind to? Let's write it again. Learn it once again. It can bind to glycam, it can bind to madcam, and it can bind to CD34. They are all the same. This is what you had to know for rolling. I'll repeat it once again. Step number 1 was coming to the margin. So step number 1 was margination. Step number 2 was rolling like a football. So yes, here we have step number 2, that is rolling. I'm trying to do a mnemonic called MRADCOP. Margination done, rolling and weak adhesion done, but ma'am, there will come a time when the football will be sick of rolling and football will say, fine, now I'm going to sit at one place. That sitting at one place is known as the next alphabet, that is adhesion. So automatically this adhesion that I'm talking about is a strong adhesion. And who causes this adhesion? This Fevicol over here is known as integrins. Please note there are two types of integrins, beta 1 integrin and beta 2 integrin. And where are they present? They are all present on WBC. So safe. Here I draw beta 1 integrin. Here I draw beta 2 integrin. I just need to know which one binds to what. So remember, beta 1 binds to VCAM1 and beta 2 binds to ICAM. How do I learn it? Now I will say beta 1 sounding like we are one, like we are united. That is how we have to learn. So we are one. Beta 1 binds to VCAM1 and beta 2 will bind to ICAM. But do you know, in pathology, in INICET, beta 2 has two more names. Beta 2, listen to this song of mine, beta 2 has two more names. One name is CD11 and 18 and the other name is going to be LAFA and MAC. I know they are tough names, but that's why I said learn it as a song. Beta 2 has two more names, CD11 and 18, and the other one is going to be LAFA and MAC. So beta 1, VR1, beta 1 binds to VCAM1, beta 2 binds to ICAM, and that is the Fevicol. The cell is stuck here, that is adhesion. Before I move forward, do you know this ICAM gets you a lot of questions in all 19 subjects? What are those? Can you tell me ICAM in pathology binds to what? Beta 1 or beta 2? It binds to beta 2 integrin. In microbiology, where will we study? So if you ever wondered, there is a Plasmodium malaria called falciparum. Plasmodium falciparum. What does it cause? It causes cerebral malaria. So have you ever wondered, how does Plasmodium falciparum go in the brain? How does it attach in the brain? It attaches to ICAM1. Similarly, in virology, there is a virus called the rhinovirus. What does rhinovirus attach to? Rhinovirus also attaches to ICAM. So remember, Plasmodium falciparum is going to attach to ICAM. Rhinovirus is going to attach to ICAM, and this beta 2 integrin will attach to ICAM. These are all your ICAM questions. What have I been studying? I'm studying a mnemonic called MRADCOP. Margination, rolling, adhesion. Ma'am, till when will it keep on sitting over here? Football can never sit at one place for very long. Football will move out. It will go out of your house only. So the next step is going to be transportation out of the house. Transmigration, the cell is going to move out of the blood vessel. Transmigration is also known as diapedesis. It's so difficult. This is not possible, ma'am. Football can't go out of my house. Assam will have to open the door. I will have to open the main gate. Then only the football will roll out. So there must be one gate over here. And that gate is referred to as the basement membrane. Who broke the basement membrane? Question number 1. So breakage of the basement membrane is done by an enzyme that you study in biochemistry that goes by the name of MMP. Matrix metalloproteinases. These are the ones that are going to break the basement membrane. And they ask you in biochemistry that matrix metalloproteinase, which metal is required for it? It requires zinc. Okay, so now fine, I have broken the door, I have opened the door, but who will help it move out? So which is the mediator? This is mediated by something known as PCAM1, also known as CD31. Please don't get confused that the lining of the endothelial cells was CD34 positive. What is useful in PCAM1 for transmigration or diapedesis is CD31. Okay, now the cell has finally moved out. I have done with the mnemonic MRAT, and I can now move on to the next part of the mnemonic, that is COP. So where is the cell? Ma'am, you said the cell had to move out, and here the cell has moved out. Here is where it is present. Now imagine you get to move out from your library. You have an option of going to the movie theater. You have an option of going to the shopping mall. You have an option of just going back home and sleeping. Nothing to do. But what do you still do? Ma'am, no. After library, we take a short break and we get back to the library and we say that I have to study because I'm very focused. I have an exam coming up. That is why we are listening to your rapid revision videos. Same is with this WBC. You've sent him out, but he's not going to go here and there for movies and shopping. He will go to his target. And who is his target? Target is a bacteria. So this step is now known as chemotaxis. Remember, it sounds like as if someone is sitting in a taxi and going to the exam hall. So tell me, WBC is going only to the bacteria, no left, right, movie and shopping. What kind of a movement does this become? This is a unidirectional movement, which is a question. Chemotaxis, it's like taxi mein baith ke jana. Someone is sitting in the taxi and going. That is unidirectional. It's going to happen in one direction. But why? You know, everyone gets distracted. WBC could have gone here and there. Why is it only going towards the bacteria? Because this is mediated by certain chemotactic agents. Number one is exogenous, means the bacteria itself, ma'am, the exam itself is like a magnet for me. In that tension, because of the exam, I will start studying myself only. So same way, this bacteria is like a magnet. It starts attracting the WBC. So it has come from outside. I call it exogenous chemotactic agent. What about endogenous chemotactic agents? We learn it by LIC mnemonic. It is going to include leukotriene B4, interleukin 8, and C5a. Please, in the exam, you will get confused between C5a or B. So here you are attracting something. So for attracting, you will use the words C5a. Okay, so finally we have been attracted towards the exam and the WBC has gone in one direction to the bacteria. What is the next step? The next step is, opsonization. This bacteria says, examiner is saying, you are coming towards me, I'll make the exam very tasty, very mazedar, I will make it. Bacteria says, I will make a coating around myself to make myself very tasty. So what is opsonization? Opsonization is covering to make the bacteria very, very tasty. So it's like adding some spices to your food. Which is the most important spice that makes every food very tasty? That is garam masala. So which is the most important opsonin? Why did I say garam masala? Because most important opsonin is IgG. IgG is that spice that you have added, which is going to make the bacteria very tasty. But if they ask you which is the most important complement opsonin, then your answer is C3b. Please over here don't write A. These are the BB. Why? How I have learnt it is, A ones were the ones that you were using for attraction. That is, you were using it in chemotaxis. And B ones are the ones, complement proteins, where you want to have badhiya khana. When you want to have badhiya food, that badhiya food is going to be opsonization. So B ones you will use in opsonins. Okay. So if someone says C5a, that is chemotactic agent. If someone says C3b, that is badhiya food, that is opsonin. So most important opsonin IgG, most important complement opsonin is C3b. Why have you done this opsonization? Because in that mnemonic of MRAT COP, finally I want to eat this bacteria, that is phagocytosis. How do you eat it? There are two methods. If you have adequate oxygen present in the body, you will use the oxygen dependent pathway of killing of phagocytosis. Oxygen dependent pathway is also known as H2O2 MPO halide system. H2O2 MPO halide system. What does that mean? H2O2 hydrogen peroxide, everyone knows. MPO is myeloperoxidase, you know. Halide, if you remember from your periodic table in chemistry, halide was nothing but the chloride family, right? So you need H2O2, MPO and chloride for killing a bacteria. But along with that, ma'am, I need one enzyme also. Which is the most important enzyme that you need? That is going to be NADPH oxidase. And if I want to just give you a quick brief over here, which gene makes NADPH oxidase? It is PH and OX. It is under the control of the FOX gene. All of this could take place only if oxygen was present. This is oxygen dependent pathway of killing, because the other pathway of killing is going to be the oxygen independent pathway, means where there is no oxygen present, then you will be using it. There are many things which don't require oxygen, but what I want you to learn, the most important example is MBP. What is MBP? MBP stands for major basic protein. And who is going to make major basic protein? Ek to I know that this doesn't need oxygen, but who is going to make it? So remember, major basic protein is made by eosinophils. And why is it being made? To kill what? So whenever eosinophils are there, this will be done to kill the parasitic infections. And this has been a previous year question, that major basic protein is produced by the eosinophils. Do they require any oxygen for killing? They do not. Okay, so which of these is the better pathway and the most potent pathway? Of course, it is the oxygen dependent killing which is most potent. So if I come down to the summary, I had a mnemonic that I had to finish off, that was MRAT-COP, and you have done that. Number one, you have studied M for what? It was M for margination. Second one was what? R for rolling. For rolling, ma'am, you required selectins, that was English Premier League EPL. Next is adhesion. For adhesion, you required integrins. Integrins were beta 1, beta 2. Next is transmigration. You remember the basement membrane was broken down by what? Matrix metalloproteinases. And which other molecule was required? It was PCAM1, also known as CD31. The next step was sitting in a taxi and going, yes, going in one direction. So chemotaxis was unidirectional. Next one was opsonization. Of course, we all know opsonization was done to make the bacteria tasty. Most important opsonin was IgG, and most important complement opsonin was C3b. Finally, coming to eating, that is phagocytosis, H2O2 MPO halide system was the most important one that you had to know. Finally, your MRAT-COP mnemonic is done. But before I go on to the mediators, I just want to tell you one difference between phagocytosis and a recent very important NEET and FMG question, that is NETs. This has been asked in 2024 of FMG, 2023 NEET, very important NETs. What is NETs? Ma'am, NETs, do you know? This is not the nets that you see in cricket practice. This is the nets that you see for killing in the body whenever you have to kill a bacteria virus. Ma'am, why do you have nets? You anyway had phagocytosis for killing bacteria virus. Now, what is the purpose of this nets? Because this is seen, this is my plan B. If there is very severe infection and my phagocytosis cannot kill, then I will have nets which will help me. So what is nets? It stands for neutrophil extracellular trap. So what is the cell that is going to help me? The cell that will help me will be a neutrophil. Okay, where will the killing happen? Ma'am, extracellular. This time, what will the neutrophil do? The neutrophil will send all the nucleus outside. All the nuclear chromatin is going to be sent where? It is sent extracellularly. Can you see? The neutrophil has sent all its chromatin outside. And what will they go and do outside? They will make traps. They will trap the bacteria virus and kill it. Do you know, for this entire process, the amino acid that is needed is going to be arginine. Okay, and now just imagine, a cell has sacrificed his entire nucleus for you. This means the cell has basically committed suicide. Neutrophil commits suicide. For whose benefit? For our benefit, for killing the bacteria. So can I say that neutrophil extracellular traps is also known as beneficial suicide, which basically means that it is committing suicide but for our benefit, right? Now recently there is a question that has come up, that if so much of nucleus has been sent outside, will your body not feel weird that, oh, nucleus had to be inside and now it has come outside so that all the bacteria viruses can be killed? So maybe your body will start showing some side effects. Side effects means that this has been associated with autoimmune disorders like SLE. Maybe what is the antibody in SLE? Anti-nuclear antibody. The body says that, oh, so much of nucleus is coming here. I have never seen this nucleus outside. Let me make anti-nuclear antibody and let me cause SLE in this patient. So the four most important question. Neutrophil extracellular traps. Question number 1 is seen in severe infection. For this, the amino acid needed is arginine. The other name is known as beneficial suicide. It can be associated with autoimmune disorders. But now if I ask you, what is the difference actually between, question 5, between nets and phagocytosis, you will say nets, where was the killing happening? Outside the cells, extracellular. Whereas in phagocytosis, we eat the bacteria, bring it inside. So it is going to be intracellular killing. There's one picture that you have in Robbins for nets which you have to know, and this is the photo. These are two photos. In the first one they have given you color coding, that green color is for the cytoplasm and orange color is for the nucleus. So orange color is for the nucleus, and in the next photo I see all of that orange color has gone outside. So what are they trying to show? Nucleus has gone outside, and that means the nucleus being extracellular is a case of neutrophil extracellular traps. I hope everyone is okay. Now we move on to one more question, then I'll start with all the clinical correlations. That question is again a recent favorite. What is emperipolesis? So remember, emperipolesis is nothing but a boy named Mark, and Mark is very, very lazy. We call him Lazy Mark. We call him Lazy Mark. Why is he lazy? Because he is not involved in any eating, killing. No, he doesn't want to do so much of work. It is just cell sitting inside another cell. One very big cell, and then one very small cell has gone and sat inside it. Is there any killing? Not at all. This is not associated with any killing. So what are the things in which you see this? As I said, Lazy Mark, you see it in M for myelodysplastic syndrome and myeloproliferative neoplasms. You see it in A for autoimmune hepatitis, which was a 2019 AIIMS exam question. Next, you see it in Rosai-Dorfman disease, which is a lymph node disorder. And next, you see it in a blood cancer, that is CLL. MDS-MPN, autoimmune hepatitis, Rosai-Dorfman, and CLL. They all show you cell in cell, that is known as emperipolesis. Now, once you're done with all of these events, what you can move on to next is going to be the clinical correlation, and these are the four main diseases that you have to know. Let us start one by one. I'll be starting with LAD, and remember, LAD refers to leukocyte adhesion defect. LAD is of three types: LAD1, LAD2, LAD3. First, do only their defects. Remember, LAD1, the way you write 1 is the same way you are going to write I. So remember, LAD1 is a problem in integrin. Which integrin? Beta 2 integrin. LAD2, the way you write 2, you are going to flip the 2 and you will get S. So this is going to be Sialyl-Lewis X. Can you see? LAD2 is a defect in Sialyl-Lewis X. LAD3, 3 for 3. So you will say, oh, this is a defect in firm T3 gene. I'll repeat it. LAD1 looks like I, so integrin. LAD2 looks like S, so Sialyl-Lewis X. LAD3, 3, so firm T3 gene. Do you know what's common to all? All of them are going to have lots of infections in children. And one more thing that is common is that all of them tend to be autosomal recessive. So their inheritance is common, infection is common, but then how will I differentiate whether a child has LAD1, 2 or 3? In LAD1, the child is going to have delayed umbilical cord shedding. The mother will say the child after birth for 1 month, 1.5 months, the umbilical cord did not shed off. That is LAD1. If the mother gets you a report saying that, oh, my child has Bombay blood group, that is LAD2. You will study more about Bombay blood group as you will go to your blood banking chapter. But for the time being, please note, Bombay blood group is the blood group in which all the antigens are absent. H antigen, A antigen, B antigen, all the antigens are going to be absent and all the antibodies are present. This means if they say anti-H antibody, anti-A antibody and anti-B antibody, all the antibodies are going to be present. I have explained this better in the blood banking chapter. If a blood doesn't have any antigens and all antibodies, that is Bombay blood group related to LAD2. Coming to LAD3, in this the child will have lots and lots of bleeding manifestations. So umbilical cord problem LAD1, Bombay blood group LAD2, bleeding problem LAD3. All three of them are autosomal recessive, all three of them have infections. Coming to the next disease that you have to know, and that is Bruton's hypogammaglobulinemia. As the name suggests, B for Bruton, and you are going to think of three things with B. Means this disease tends to occur more commonly in which gender? It occurs more commonly in boys. What kind of a defect is it? It is going to be a B cell defect. And what gene is defective? It is a BTK gene defect. Boys, B cell and BTK gene defect. Okay, let's move on to the next word. Hypo. Hypo means less. Gamma globulinemia. So actually there is a decrease in immunoglobulin, especially immunoglobulin G. Did I just teach you immunoglobulin G is the garam masala? So if the garam masala goes missing, this means the kind of opsonization will happen? No, ma'am. There is going to be defective opsonization that you will see in this patient. So garam masala missing? Opsonization problem. Coming to the next disease, and that is going to be Shediac-Higashi syndrome. So what is Shediac-Higashi syndrome, which we write as CHS? It is a disease which is a defect in LIST gene, LIST for something to do with lysosome. So it's a lysosomal defect, and the mnemonic for Shediac-Higashi is going to be the word Shediac. So number one, the mother will say that my child is having a lot of CNS problems. How does a mother in India get to know about her child having brain neurological problems? As per mother, it is a child who is not having adequate milestones, or a child is not getting grades in school. The mother thinks he has some problem. So mother comes to you saying that my child had to drop out of school because of poor grades. Coming to the next, HE for hemorrhage. There will be bleeding from many sites. DI for decreased immunity. So please note, decreased immunity means the mother will say my child is having ear infection, throat infection, pneumonia, lots of infections again and again. A stands for albinism. Please remember, these children tend to have silvery gray hair. That is very, very important finding. So this, you can even visualize yourself as the child comes inside the OPD. And finally, what is K? K sounds like K, that is coarse granules. If you look at a pathology slide, you will be able to visualize that. Look at this. There are some coarse granules that are going to be present in the cells. So coarse granules are seen. That is how you study. CNS, hemorrhage, decreased immunity, albinism, coarse granules, LIST gene defect, that is Shediac-Higashi. Coming to the last one, CGD, chronic granulomatous disease. It has 3 alphabets because everything will be something 3 over here. So firstly, there is a defect in an enzyme called NADPH oxidase. I think we all remember this was the enzyme that was involved in phagocytosis. So of course, this is actually a defect in phagocytosis. And which gene? So we all know PH and OX, that is what makes it. So it is going to be a FOX gene defect that I notice. What happens in these? These patients have a lot of infections, but they are going to be catalase positive infections. Go to the microbiology RR where I've taught you infections which are catalase positive. Staphylococcus, Klebsiella, Pseudomonas, these are all catalase positive. The patient keeps having catalase positive infections. How will you do the diagnosis? You will do a screening test. Screening test is known as the NBT test. What is the full form of NBT? It stands for nitro blue tetrazolium. Only full form to know because by chance examiner writes the full form. So nitro blue tetrazolium test is going to be a screening test. Which is the diagnostic test? It is going to be the DHR test. DHR is dihydrorhodamine. You don't have to know the full form, but you have to know which is screening and which is diagnostic. So please note, this is just a way of learning. NBT sounds like nibba-nibbi. Nibba-nibbi are those young teenage couples that we refer to. So that young small test that we use for this disease is NBT, and the diagnostic test that we use is going to be DHR. So please note, CGD has 3 alphabets, NBT has 3 alphabets, DHR has 3 alphabets. NBT being nibba-nibbi is the smaller test and DHR is the diagnostic test. If I take up a quick question over here, you have a 4-year-old child who's come with a lot of infections with staph and strepto, and peripheral blood smear shows neutrophilia. There is a problem in neutrophilic rolling, and the patient is found to have a very rare blood group, that is Bombay blood group. As soon as I know Bombay blood group, I know we are dealing with LAD2, which is making all the sense. Okay, let us move forward and now go on to the next question or the next topic, which are going to be mediators of inflammation. So of course, we have tables and tables that you have to study under it, and without a delay, we are going to go ahead. Let us start with the first, and you might get a little scared of these tables, but don't worry, we are going to study it together and we will definitely do a good job here. What are the mediators of acute inflammation? Number 1 is going to be histamine and his cousin brother, that is serotonin. So where are they coming from? If I ask you what is their origin, so the richest source that you have for histamine is going to be the mast cells. There's one question of mast cells that I've taught you in Hemat also. What is the special stain for mast cells and basophils? That is going to be toluidine blue. This is something you will study in hematology. Special stain for mast cells and basophils is going to be toluidine blue. So toluidine blue for mast cells, and mast cells release histamine. Serotonin, what is the richest source for serotonin? Earlier the richest source was said to be platelets, but now the richest source is said to be enterochromaffin cells. Entero word tells me these are present in the intestine. Repeating, richest source of histamine is mast cell, richest source of serotonin is enterochromaffin cells. Their sources are different, but I call them cousin brothers. So that means that parents are different, but they will be best friends and they will do the same job all throughout. So what are their jobs that I have told you? Number one, I taught you they cause vasodilation. Then next I taught you they cause the increased vascular permeability, which is the hallmark event. And we all know that they are responsible for asthma. So that means they cause bronchoconstriction. That's how asthma occurs. So as I said, parents are different, but they function together. So they are cousin brothers. Okay, let's move on to the third mediator, which is lysosomal enzymes. I'm not writing the fact that they come from lysosomes. Which type of lysosome? So lysosomes have three granules: primary granules, secondary granules, and tertiary granules. Know their names. Primary means the first alphabet. The first alphabet is A. So primary granules are known as azurophilic granules. Okay. Secondary S and specific S. So secondary granules are known as specific granules. Tertiary 3 and third alphabet is C. So tertiary granules are known as C particles. So remember, primary is azurophilic, S as secondary specific, and tertiary is going to be C particles. Now you need to know that what are these granules actually going to release. Again, we will go a little mnemonics wise, otherwise it's tough to learn. So remember, let's start with the C particle. The way you write C, you are going to draw a G out of it. And C particles release what? Repeating, if you can see over here, what do C particles release? They are going to release G for gelatinase. Okay, coming to the next. What do the secondary granules release? Ma'am, secondary granules are known as specific granules. So of course, what will they release? They will release a specific type of collagenase, that is type 4 collagenase, which breaks only and only type 4 collagen. So specific granules will release specific collagenase, and they also release lactoferrin. How I have learnt it is, instead of lactoferrin, we learn it as lactoferrin, so that I remember that, oh yeah, lactoferrin was coming from secondary granules. Everything else comes from primary granules. And in primary class, what did all of you learn? In primary class, we used to learn A, B, C, D, E. Or you can also learn that, okay, from tertiary gelatinase comes, from specific, and lactoferrin comes. So then everything else comes from primary. Just read them one, A, B, C, D, E. What is that? So A stands for acid hydrolase. B for what kills the bacteria in phagocytosis? Myeloperoxidase. C for cathepsin, D for defensin, and E for elastase. So please remember, we have acid hydrolase, bacteria killer, myeloperoxidase, cathepsin, defensin, elastase. Primary class mein you learned ABCDE. Secondary and specific is lactoferrin and specific collagenase, and tertiary C particle is going to be gelatinase. Okay, so now once you're done, can you quickly tell me, gelatinase is released by, quick, primary, secondary, tertiary. Ma'am, you said C particles are going to release gelatinase. I can see C particles over here. C particles are what? Primary, secondary, tertiary. A, B, C, third alphabet. C particles are tertiary granules. So you've done 3 mediators. Do you know what category of mediators were these? They were preformed mediators. They are always present in your body. Histamine, serotonin, lysosomal enzymes, they are always present in your body. Now I move on to mediators which are going to be newly synthesized. They will be formed when you get infected. What are those? So newly synthesized mediators include, number 1, nitric oxide, and number 2, platelet activating factor. So nitric oxide and platelet activating factor, let's know their functions. Nitric oxide, I think everyone knows, this is something which is also given as a therapy in MI, and it has been given by, because it causes vasodilation. And it will keep the platelets also separate. It will not let them aggregate. It will not let a blood clot form. So remember, it opens everything. Nitric oxide is going to be for opening everything. What will it do to the blood vessel? Dilate. What will it do to the platelets? It will keep them separate, no aggregation. Now let's come to platelet activating factor. The word only tells you that this is going to activate everything, means it's going to narrow down everything. Matlab, it is going to cause platelet aggregation and it is going to cause vasoconstriction. So can I say they are opposites? Nitric oxide was opening everything. Platelets were not getting aggregated. They were loose. Blood vessel was also loose, dilated. Platelet activating factor will aggregate the platelets and it will bring the blood vessel close, vasoconstriction. Now let's move to the third one, that is going to be chemokines. If you see all of chemokines, I can see 2 alphabets. I can see a lot of C's and I can see a lot of X's, right? So remember, the C is going to stand for cysteine and the X is going to stand for any amino acid on this planet, which you don't have to learn. So now tell me, we will start from here. The first one is CXC, means there are 2 cysteines and 1 amino acid. This is known as alpha chemokine. Okay, then after this, what I do, I remove the X. What am I left with? CC. So CC is known as beta chemokine. Then I remove another C and I'm left with single C, and that is known as gamma chemokine. So remember, CXC, remove the X, you are left with CC, remove another C, you are left with C. What do they release, and ma'am, what is their function? So remember, what are their examples? They are all things which are going to have certain examples. ये सिर्फ इनका structure था. This was just a structure of these you are going to learn. So what is the example of CXC? It is going to be interleukin 8. How I have learned is that CXC, you can convert X into 8. So this is how you will learn. It is interleukin 8. And what does it attract? It attracts the neutrophils. Coming to the next one, the last one first, that is C. Single C is going to also look like the alphabet L. So the example for this is lymphotactin, and common sense tells me that lymphotactin is something which will go and attract which cells? It will attract the lymphocytes. Yes, again common sense, fine. Coming to what is left, ma'am, CC. CC is what you use in an email when you have to send your email to random people and you put all their names into CC. So CC is everything else. For example, CC has eotaxin. Whom do you think it's going to attract? It's going to attract the eosinophils. Then MCP. MCP, whom do you think it is going to attract? It is going to attract the monocytes. And RANTES. RANTES is going to attract whom? It is going to attract the T cells. So all the miscellaneous ones are going to come in CC. In CXC, it is interleukin 8, and in single C, it is going to be lymphotactin. These were alpha, beta, gamma chemokine, but I have one rare one, very weird one sitting over here. CX3C means it has 3 amino acids which no one knows, and the name of this is also no one has heard of it. So you just learn it once and you forget it, and we'll never get to hear it again in life. What is the example of CX3C chemokine? It is going to be fract alkene. So let me just ask you a question to see if you remember. CC includes which of the following? So don't be in a hurry, think. Where was interleukin 8 coming? Ma'am had said from CXC you can make 8, okay. Then where was lymphotactin? Ma'am said that single C and L go together, so lymphotactin was C variety. Fract alkene was that weird sounding thing, CX3C. So then ma'am said whatever is left will go into that CC email category, that is eotaxin. That has been a previous year question. So you are done with nitric oxide, PAF and chemokines. Now we move on to the fourth one, and that is going to be the cytokines, which include interleukins, TNF and interferons. So tell me, which are the ones which are going to cause fever? It is interleukin 1, interleukin 6 and TNF alpha. So now if I have to ask you what all does TNF alpha cause? So you will say number 1, ma'am, I know it causes fever. Second, that whenever we have fever, we stop feeling hungry. So basically there is a decrease in appetite that occurs, and that is with TNF alpha. Also, this has been associated in the pathogenesis of septic shock. A small update over here, or I can say a mnemonic that I want to give you. Remember, it's TNF alpha for no appetite, because you will be given options like TGF alpha, TGF beta, TNF alpha, and you will get confused. So over there, always remember this mnemonic: no food appetite. That is for TNF alpha. Okay, so remember NF alpha means no food appetite for TNF alpha. Okay, now let's move forward. Which is the interleukin which can start inflammation also, and it can stop inflammation also, and those are going to be interleukin 4 and 6 can do both the works. Which is the interleukin which is only anti-inflammatory? That is interleukin 10, and you learn it as AN10 inflammatory, because this is the one that can only stop, or anti-inflammatory action it has. Which is the interleukin for T cell maturation? It is interleukin 7. The way you write 7, you can make a T out of it. So again, easy to remember. Which is the interleukin for eosinophil activation? So eosinophil, ABCDE is the 5th alphabet. This means interleukin 5 for eosinophil activation. Finally, for neutrophil recruitment without a mnemonic, you learn interleukin 8. There's one more interleukin that you have to know, is which is the interleukin that regulates APR, and the answer is interleukin 6. But my question is, what is APR? APR stands for acute phase reactants, which basically means that you must have seen in COVID, we were getting some blood tests. Some levels were increasing in the blood and some levels were decreasing in the blood. So whenever someone has fever, all the things that are going to increase in the blood, that is going to be a positive APR, and all the things that are going to decrease in the blood are going to be known as negative APR. So for example, we remember C-reactive protein was increasing, ferritin was increasing, hepcidin, haptoglobin, fibrinogen, procalcitonin and SAA. All of these are what? They will be known as positive APR, so they increase in the blood. Very long list. list? I cannot remember. So I learned the easier list, and the easier list is learned as TAN, which means which are the ones which are the negative APRs. So remember, everything that is transferrin, transcortin, transthyretin, those are negatives, and A for albumin. So trans, albumin, they are the negative APRs. You learn it with the mnemonic TAN, which means that albumin, trans things, they are all going to decrease in the blood. And who decides what will increase and what will decrease? It is decided with interleukin 6. Another thing that I want to tell you is that interleukin 6 will have a role somewhere later on, which I'm just writing over here, and that role will be in anemia of chronic disease when we study hematology, which is very important. Another question that is being asked is, out of all of these, which is considered as a marker for sepsis? So procalcitonin has come across as a marker of sepsis. Again, a question that is being asked a lot in pediatrics and medicine. Let's move forward. We have done all the interleukins and the TNFs. Now we move on to the last, that is interferons. Interferons are of three types, that is interferon alpha, interferon beta, and interferon gamma. So you get two types of questions. Where do they come from? What are their sources and how do they act? So their sources are learnt with the mnemonic LFT, which basically means that interferon alpha comes from leukocytes. And which leukocytes? For example, very commonly macrophages. Interferon beta comes from fibroblasts, and interferon gamma is going to come from the T helper 1 cells. So LFT, leukocyte fibroblast T helper 1 cells, for their sources. What do they work as? So remember, for alpha, beta, gamma, their functions are going to be alpha, beta, and gamma. That is how you learn it. So this means interferon alpha has antiviral properties. Interferon beta is used for the treatment of a brain disorder, and that disorder is multiple sclerosis. And interferon gamma has two functions. So G for gamma, and that is going to be granuloma formation. And secondly, another G that it is used, remember there was a disease called CGD, chronic granulomatous disease. So it is used for the treatment of chronic granulomatous disease. So remember, A for A, B for B, and G for the G's that you have over here is how you are going to learn it. This same concept also comes to you in microbiology, so I will not be dealing with it again. It is finished over here. Now, if you realize, I was doing newly synthesized mediators, in which the first one that I did was nitric oxide, followed by PAF, followed by chemokines. The fourth one that I did was all the cytokines, and now I'm ready to go on to the fifth one, that is the arachidonic acid metabolites. So what is arachidonic acid? This is something that you study in biochemistry. It is a 20 carbon compound, and where does arachidonic come from? It comes from the phospholipid. So how? Phospholipid has to be broken down obviously by phospholipase. So it is broken down by phospholipase A2 and phospholipase C. And after it is broken down, it is going to form arachidonic acid. But ma'am, I'm not interested in arachidonic acid. I'm interested in what further happens. So from arachidonic acid, there are two pathways. One pathway is known as the COX pathway, which is cyclooxygenase enzyme acting on it. And that results in the formation of two things. One is going to be prostaglandins. That is very, very important. And the other one is going to be thromboxane A2. So prostaglandins and thromboxane A2s are formed from the COX pathway. The other one is referred to as the LOX pathway, which is lipooxygenase, and that results in the formation of again two things, that is going to be leukotrienes as well as lipoxins. So let us start studying both of them in one page along with the basic pharmacology aspect integration. I'm first dealing with the COX pathway, which says that it will form prostaglandins and thromboxane A2. So here we have arachidonic acid. It is acted upon by two things, COX1 and COX2. And which is the first prostaglandin that is going to form? It is going to be prostaglandin G2. From G2, the next one, after G comes H. So, okay, the next one that is going to form is going to be prostaglandin H2. And H I have learnt as whole, because after this, the whole spectrum will form from it. So after H, the next alphabets that you have are going to be PGI2. So what is PGI2 after H? Of course, PGI2 is formed. PGI2 is prostacyclin. From H, another thing is formed, that is thromboxane A2. So I've gone only ahead. This means G, H, I, and I have also taken care of thromboxane A2. But what about the alphabets before G? What about D, E, F? So remember, this is H only, which is going to give the whole spectrum. This means PGD2, PGE2, and PGF2 alpha. All of these are going to come from H itself. So let's repeat. The first prostaglandin to form is G. After G comes H, and H is for whole spectrum. So after H comes I and thromboxane A2. Before them, D2, E2, F2 alpha. Everything comes from H. First, you get a question on these two. Why did I take them together? Because they are opposites. Prostaglandin I2 is also known as prostacyclin, and TXA2 is known as thromboxane A2. I would suggest learn any one. For example, thromboxane A2 is going to cause what? Aggregation. It brings everything close. It aggregates the platelets. Okay, what does it do to the blood vessel? It brings it close, vasoconstriction. Whereas PGI2 is going to inhibit everything. It inhibits platelet aggregation and it opens the vessel. So I can learn that A for A and I for I. Thromboxane A2 aggregates the platelets. Prostacyclin inhibits aggregation of platelets. Thromboxane A2 will cause vasoconstriction. Prostacyclin will cause vasodilation. Let's move on to the next. What does PGD2 do? As the word D tells you, it causes vaso, D for dilation. So that is also settled. What does PGE2 do? So E is the sound that you make whenever you have any pinches you or you have pain. What do you say? You say E, right? So this is the one that is going to cause pain. I just want you to make a small little note over here that whenever someone asks you in inflammation, which are the two things that cause pain, one you have already learned is E, that is PGE2. Another one is going to be bradykinin. So that is also responsible for pain. Now coming to PGF2 alpha, with F you will learn something to do with female. So in gynae there is a drug which is known as carboprost, which is used for cervical ripening. So remember, it is going to be associated with female drug. Okay, these are all your arachidonic acid COX pathway. But what I want all of you to know is that if I go into the details of pharmacology, COX1 and COX2, do you remember what other function does COX1 have? COX1 is said to be the guard of my stomach. It is said to be gastroprotective. It's a very important guard or a policeman of my stomach that I have so that I don't get damaged with my own acid. Now remember that if I want to do the treatment, what do I give? Usually for the treatment, I give NSAIDs or I give aspirin, right? So what does aspirin and NSAIDs do? They do both. They are going to inhibit both COX1 and COX2. This means my gastroprotective action is gone. If COX1 is not working, what will the patient land up with? The patient will land up with peptic ulcer disease. So ma'am, please don't touch this COX1. Don't give drugs which are going to damage my guard and my policeman. Just give drugs which are going to act on COX2. So remember, now what we give is, we give selective COX2 inhibitors, and those come by the name of coxibs, like celecoxib, etoricoxib. So all these coxibs are going to be just COX2 inhibitors. I don't touch the guard, I let the guard function. Now after this, if you've done the COX pathway, you go on to the LOX pathway. So here what I'll have arachidonic acid, which is acted upon by two LOX. One is 5-lipoxygenase, one is 12-lipoxygenase. 5-lipoxygenase gives leukotrienes. The first leukotriene is, here the story is simple. It starts from A, B, C, D, E. Simple. So leukotriene A4, and A4 is going to give rise to leukotriene B4. A4 is only going to give rise to C4, D4 and E4. And please note, have I taught you leukotriene B4 somewhere else? There was a mnemonic called LIC for the chemotactic agent. Yes. So L was for leukotriene B4, responsible for chemotaxis. Where do you study leukotriene C4, D4, E4? They are the ones which are responsible for acting on the leukotriene receptors. They are the ones which cause what? Ma'am, in the lungs, they act on the leukotriene receptors of the lung and they cause bronchoconstriction. So basically, they cause asthma. And now I can say that, okay, so if I want to treat, let's assume I want to treat asthma. So these are the people who are causing asthma. So one option is that I stop this pathway. So what drug can I give? I can give a drug called Zileuton, and Zileuton is going to go and stop 5-LOX. But the problem is, Zileuton will, okay, it will stop all this, but Zileuton is also stopping chemotaxis. I don't need to stop chemotaxis. I am having a problem with these three. So what is the best drug that I can give? I can probably give a treatment of leukotriene receptor antagonists, because only C4, D4, E4 is causing a problem, and they come by the famous names of Leucast, like Monteleucast, Zafirleucast, right? Monteleucast is a drug that you have studied the most. So what will they do? They will go and inhibit only this C4, D4, E4 variety. So Zileuton is not given for asthma because I don't want to stop everything. I just want to stop these people. So I give leukotriene receptor antagonists. This was all from the 5-LOX pathway. Do you know there is a 12-LOX Goldilocks pathway, which gives rise to what? It gives rise to lipoxins. And what is lipoxins? Lipoxins have an anti-inflammatory action. Everything that I've taught you till now was starting inflammation. Lipoxins are the ones that stop inflammation. So coming all the way back, arachidonic acid with 20 carbon compound, where does it come from? It comes from phospholipids. It is acted upon by cyclooxygenase. It forms prostaglandins and thromboxane A2. It is acted upon by lipooxygenase. It forms leukotrienes and lipoxins. Lipoxins are the ones which stop the inflammation. The last newly synthesized mediator that you have to know is going to be the very, very famous complement system, right? So these are something which is partly newly synthesized, partly there in the body always. And where are they present? They are present in the plasma. So what is the complement system? I'm sure all of you have seen this flowchart in biochem, in path, in micro, in medicine. It's very complicated. So right now in the rapid revision, I'm not going into the complications of this. I'm making it into a simpler version. So what do you have when we talk about a complement system? Ma'am, there are 3 pathways that I can see over here, but all of them ultimately come to a common point and they are going to end at a common place, right? So let me look at these 3 pathways in a better way. There is a classical pathway, Mannose pathway, and alternate pathway. When does my body decide which pathway to start? So whenever there is formation of any antigen and antibody, we start with classical pathway, particularly which antibody? We are talking about IgM and IgG, the acute and chronic inflammation antibodies. Whenever they are coming making antigen antibody complex, I start the classical pathway. Okay. What do you think for alternative pathway? So which antibody? It must be A for alternate, A for IgA will start the alternate pathway. And what about Mannose pathway? Mannose is something I saw in bacterial cell wall, if you remember. So this is something which is triggered in general by bacteria and organisms. So repeating, classical by the antigen antibody, IgM and IgG, alternate by IgA, and Mannose by microorganisms. Next, if you notice, the classical pathway starts in a classical way, that is from C1. The alternate pathway has to take an alternate route and it starts from C3. The Mannose pathway can start from C1, but nowadays they are saying the starting point is C2 and C4. I'll repeat it once again. The classical pathway is starting from what? It is starting from C1. The alternate pathway has to start from C3, alternate route. And the Mannose lectin pathway is basically starting from C2 and C4. But wherever they may start from, they ultimately come to C3, C5, ma'am, they ultimately converge. And when they converge, what is the end result that all of them are going to form? What is the end formation? It is going to be MAC. What is MAC? Membrane attack complex. What is MAC made up of? Ma'am, the composition is C5b to C9, means C5b, 6, 7, 8, 9. These are the things that are going to make up MAC, and the name tells me membrane attack complex. It's going to attack. Whose membrane is it going to attack? So of course it is going to attack the bacterial membrane. It causes bacterial lysis. I hope everyone has understood this, because now comes that which is the most common complement deficiency known in humans. It is C2. When someone has early complement deficiencies like C1, C2, C4, these are the early numbers now. So when someone has early complement deficiencies, that has been associated with an autoimmune disorder called SLE. Early, if you've spoken about, now you talk about late. What was the late from C5b to C9? So when MAC deficiency occurs, usually the person ends up having capsulated organism infections. And one example of that can be meningococcus. But in general, any organism that has a capsule, those kind of infections will start occurring. But mostly you get MAC deficiency, meningococcus infection. Now there's a question that came recently in the FMG and the NEET PG exam both, is a case of hereditary angioedema. What is hereditary? HAE. There is a case known as hereditary angioedema. This much everyone can understand, that, oh, patient is going to have swelling, edema episodes. Why does that happen? Because this is a C1 inhibitor deficiency. Now I have to break it down. First, I know what is C1. Yes, ma'am, we remember C1 was where the pathway was starting. But do you know in the body you have a C1 inhibitor? Why? Because do you think you want this pathway to keep on going forever and ever and ever and keep destroying your cells? No. Ma'am, normally what happens is that this C1 is controlled by something called C1 inhibitor. So we write it as C1 INH. Normally I control it, that I don't want it to occur all the time. When bacteria will come, then we will start this pathway. Till then, please keep it stopped. So who keeps that check? Who keeps that stop? It is C1 inhibitor. Just imagine if someone has C1 inhibitor deficiency. Ma'am, C1 inhibitor was the controller of C1. Someone does not have that controller, C1 inhibitor deficiency. This means now the pathway has no control. There is going to be uncontrolled pathway that is going to be noticed, and that is why patient is having a lot of edema. So remember, take home message, normally who controls and stops this pathway? C1 inhibitor. But if C1 inhibitor goes deficient, then the pathway will become uncontrolled, and that is why you can see there is edema. Where all is the edema present? I can see the edema on the eyes, I can see the edema on the lips. Till now I'm not that worried, but nowadays you are seeing a lot of cases coming to you with laryngeal edema. And laryngeal edema means that the patient is going to have respiratory distress. And of course, if someone comes to you with respiratory distress, you don't take him up on OPD basis. This is going to be a medical emergency. So this is a recent question that has been asked. Hereditary angioedema is a deficiency of C1 inhibitor. Finally, done with all the mediators, and that also finishes off all of your acute inflammation finally, because now you're ready with chronic inflammation, granulomatous inflammation, and wound healing. So the next, quickly we'll try to wrap it up in 20 minutes. When I start with chronic inflammation, I think I've told you the cells were lymphocyte, macrophages, and plasma cells, and the most important cell out of these was macrophages. More than that, more than anything, I want to tell you that each macrophage, does it have any other name? Yes, in the tissues I also call it as histiocytes, but in different tissues I have different names. So for example, what do I call it in the brain? In the brain, I know everything is given the word glia. So macrophage in the brain is referred to as what? It is known as microglia. Then in the lungs, what is it called? So lungs, we know everything in the lungs is made of carbon, dusty air, pollution. So we can call it dust cells, or we can just call it macrophages in the lungs, that is alveolar macrophages. In the liver, I think no one needs to know, it is known as the Kupffer cells. In the kidney, we know in the kidney we have something called mesangium, so it is known as the mesangial cells. In the spleen, it is known as littoral cells. This is something you might not have heard of. So remember, in the spleen, what are you going to call it? You are going to call it the littoral cells. Spleen is known as littoral cells. In the placenta, gynae question, macrophages are known as the Hofbauer cells. You get a question. It is the Hofbauer cells which is going to be the site of residence of Zika virus. That is a microbiology question. Coming to the next, in the bone, it has to be osteo, so it is osteoclast. And in the synovium, it has to be synovio, so it is synoviocytes, to be very precise, type A synoviocyte. So let's do a quick repeat. In the brain, it is glia. Lungs, it is alveolar macrophage or dusty cells. Liver, Kupffer cells. Kidney, mesangium. Spleen is littoral. Then placenta is Hofbauer cells, where the Zika virus goes and sits. Bone is osteoclast, and synovium is synoviocytes. Now, if I go back, I've studied everything about macrophages and chronic inflammation, but do you know there is an inflammation called granuloma? Granuloma is a type of this chronic inflammation only, and you get a lot of questions on it. So let me study what exactly is a granuloma, and this is the picture of a granuloma that I've got already drawn. So there are 5 parts and we have to label it. Let us start. If I look right in the center, what I see in a granuloma is known as caseous necrosis. So, you know, all granulomas will not have it. Some might have it and some might not have it. So, I'll give you an example. Necrosis means death, right? So, either you can have necrosis, that will be known as a caseating granuloma, or you will not have necrosis, that will be known as non-caseating granuloma. So, the first thing that you need to know, TB can show you both of these granulomas with and without caseous necrosis. Sarcoidosis can show you both of these granulomas with and without necrosis. But obviously we know that in TB, the more common one is going to be caseating granuloma, and in sarcoidosis, the more common one is non-caseating. So if you get a question of marking both, always mark both. If you have to select one, then caseous necrosis for TB and no caseous necrosis for sarcoidosis. Do you know that apart from that, sarcoidosis also shows you another granuloma that is known as the naked granuloma. And what do you mean by that? So if you look at any normal granuloma, what did I tell you? That in the center there is caseous necrosis. But now look at the extreme periphery. What do you see right at the periphery? That is going to be a lymphocytic collar. It's made up of lots and lots of lymphocytes. Do you know which lymphocytes? T helper 1 cells. Where did I just read it? I had studied something called interferons, and I had told you that interferon alpha, beta and gamma come from LFT. T helper 1 cells release what? They release interferon gamma, and I know G for gamma and G for granuloma formation. Interferon gamma is needed. That is why I know that, oh, T helper ones are sitting on the outside over here. It's like a collar, it's like a covering or clothing that you've put on this granuloma. And if I end up removing this clothing, then what will happen? Ma'am, the granuloma, if you remove clothes, the granuloma will become naked. So if lymphocytic collar is absent, now it will be called as a naked granuloma, and that is what I see in sarcoidosis. So sarcoidosis shows you two things, a non-caseating granuloma and it shows you a naked granuloma. Now coming to the other aspects, what are the cells that I see? One, I can see these simple round looking cells, because ma'am, you are saying this is a chronic inflammation, and for chronic inflammation you've told us most important cell is a macrophage. So we will go with a macrophage. Okay, but this is simple looking. What if I stretch it a little? Can you see here I have stretched the nucleus a little. I have made it into a slipper shaped nucleus. If I ended up making it into a long slipper shaped nucleus, so you'll say, ma'am, earlier the macrophage was round, now you've made it slipper shaped. Basically you've modified the macrophage, right? And modified macrophage is known as the epithelioid cell. Remember, this is the most important cell of a granuloma. This is the most important cell in a granuloma. Finally, what I'll do, I will take lots of these macrophages and I will fuse them together. Can you see 10-20 macrophages I have fused together? What are those? Known as multinucleated giant cells. What are multinucleated giant cells? They are said to be the fusion of the macrophages. So everything is macrophage. Simple cell is macrophage. I stretch it into a slipper, it is a modified macrophage or an epithelioid cell. I fuse all of them together, they become multinucleated giant cells. These are the components of a granuloma. In detail, you get a question on multinucleated giant cells. So these are all the giant cells that you have to know, which we will study in a fill in the blank format. So first thing that I will ask you is, all of these giant cells, you have to focus on the nuclei. Look at this. If the nuclei are arranged like this in the form of a horseshoe, then the horseshoe nuclei are referred to as what? They are known as the Langerhans giant cells, and Langerhans giant cells are seen in cases of TB. Please note, it is not Langerhans cell, not Langerhans. Why? Because now you will think a lot. Where do you see Langerhans cell? Those are antigen presenting cells present in the skin. They are not Langerhans giant cells. Okay, so these are Langerhans giant cells, and Langerhans cells are totally different. Don't mess them up. Coming to the next, if I see nuclei which are arranged like this in a round fashion, so in a round fashion we call it wreath-like nuclei, and these giant cells are referred to as two-tone giant cells. So we learn everything in two-tone is going to be goal, round. The nuclei are also round, and this is seen in diseases where the person will also have round, fatty things. What are those round, fatty things? So basically it is seen in xanthoma, and for those who don't know, xanthoma basically happens to be a lipid disorder. Coming to the next, if the nuclei are all over, basically they are all haphazard nuclei. So haphazard nuclei are seen basically in foreign body giant cell. Examiner will have to give me the the history of a foreign body. For example, examiner will say there is some talcum powder or there is some suture material. Next is the most important for microbiology, which I will have to zoom in for you. If you see a giant cell which has these intranuclear, can you see inside every nucleus there is a pink color dot? If there are intranuclear inclusions and also in the cytoplasm remotely, it's looking some pinkish color dots. So if there are intranuclear and intracytoplasmic inclusions, those are referred to as the Worden-Finkelday giant cells, and Worden-Finkelday giant cells are seen in measles. Please remember, W for Wardens, I invert it and I get M for measles. So these are going to be seen in a case of measles. The giant cells are not over. We are left with the famous owl eye. Now you just have to note what is the color of the eyes. If the color is pink or blue, two colors of pathology. If the color turns out to be pink or eosinophilic, then you will call it a Reed-Sternberg cell, and that is seen in case of Hodgkin's lymphoma. Whereas if you get to see these blue color eyes, then blue color eyes means basophilic, and those are seen in cytomegalovirus. How will you learn? Remember, Reed-Sternberg cell is sounding like red, so it will have reddish pinkish eyes, and cytomegalovirus will have bluish eyes. Coming to the last one, this is known as, I can definitely see lot of nuclei, lot of giant cells. These are the giant cells that you see in gynae when there is someone infected, say genital ulcer or a vaginal infection with herpes. Do you know what kind of cells do you see, ma'am? As you said, we see multinucleated giant cells. Yes. But what else? If I first zoom in and show you, of course you are seeing multinucleated giant cell. There is no doubt about it. I can see lots and lots of nuclei over here. But can you see all those nuclei are trying to fit into each other? I cannot make them out separately. They are trying to fit into each other. That process is known as molding. So the next process is known as molding of the nuclei. And also, if you look carefully, they are darker at the periphery. I will again zoom in and show it to you. They are darker. Ma'am, the nucleus is more blue at the periphery and the center is a little white. That is known as blue at the margin. So the next M is known as margination. So the trick is that whenever in the exam you see 3 M's, multinucleation, molding and margination, they are trying to indicate herpes to you. So quickly, if you see in 10 seconds, Langerhans giant cell, horseshoe shape, Langerhans, not Langerhans, that is seen in TB. Now we come to the round wreath-like, seen in round two-tone, round lipid disorder, foreign body giant cell, all haphazard, intranuclear intracytoplasmic inclusion, Borden-Finkelday giant cells of measles, owl eye appearance, red color, pink color eyes, so Reed-Sternberg cells, blue color eyes, so cytomegalovirus, margination, molding and multinucleation is going to be herpes infection. These were all the giant cells, but what about all the granuloma shapes? Now number one granuloma shape is, if you get to see this kind of a granuloma, which is all of stellate, then stellate granuloma is seen in 2 conditions. Number one being the cat scratch disease and the second one being lymphogranuloma venereum. The next one I don't even have to describe, because this is what? This is looking like a donut, right? So when it's looking like a donut, I call it a donut granuloma. And from that donut, if I make a line out of it, then I get the fever also. So this has been associated with Q fever, and an AIIMS exam question for INI CET aspirants is important, and that has been associated with allopurinol drug also. Finally, coming to the granuloma, in which what can I see? I can see there are 2 parallel lines like this, and in those 2 parallel lines, I can see some dots. So those granulomas are referred to as the Dirk granuloma, and Dirk granuloma is seen in D for Dirk, D for Dimag, something to do with the brain. So remember, what in the brain am I seeing over here? I am seeing cerebral malaria, and when I say cerebral malaria, we all know I'm talking about Plasmodium falciparum. Yes, so Dirk granuloma is going to be seen in Dimag, that is cerebral malaria. What is the special stain? So remember, for falciparum, the special stain is going to be the field stain, and that is what I have given you as a blue color picture over here. So star is stellate, cat scratch and LGV, donut looks like a donut, so Q fever and allopurinol, Dirk granuloma, Dimag, cerebral malaria caused by falciparum, special stain for falciparum is the field stain. All the chronic inflammations and granulomas are done for you. The last topic of this chapter is going to be wound healing. So this is a surgery topic, but I'm taking up quickly over here because it's important. Whenever I talk about wound healing, they will ask you what are the events of wound healing that happen in different days. So first, remember the days. You have to learn it as 0, 1, 2. That is simple in order. 0, 1, 2. After that, you learn it as 3, 5, 3. So that means day 3, day 5, and day 21 can be learned as week 3. So I will learn it as 0, 1, 2, 3, 5, 3. Repeat with me, 0, 1, 2, 3, 5, 3. Now you will tell me, when someone gets hurt, what is formed first? Of course, it is going to be blood clot. In fact, ma'am, blood clot is just not formed on day 0. Blood clot will stay for 48 hours at least. So the first thing that everyone has to know is going to be blood clot. What is blood clot made up of? It is made up of platelet and fibrin. So if someone asks you which is the first cell to come up, it is always going to be platelet. Okay. Right now I'm focusing on 0, 1, 2. Which inflammation do you think for the first 48 hours? Acute inflammation. What are the cells of acute inflammation that you have to know? These are going to be the neutrophils, undoubtedly. So they come up next. Then on day 2 is a very interesting thing. On day 2, there is formation of a thin epithelial layer. And what I want all of you to remember is that whenever you get hurt, all of you have gone through this and your parents have really objected that you should not be doing it. Whenever you get hurt, by the second day, you will notice on top of your blood clot, you see a thin white layer. And all of us have a habit, we peel off that layer and we start itching it. Have you all done that? Peel off your blood clots, your body doing so much of work and you peeling it off. Really not done. But what are you peeling off? You're peeling off that thin epithelial layer, and you do that at day 2. So next time you won't do that. So that thin layer comes by day 2. 0, 1, 1, 2 is done. Acute inflammation phase and neutrophils are done. Now we enter to the second part, that is 353, means I have entered into chronic inflammation. Most important cell of chronic inflammation is going to be macrophages. Next, I ask you one more thing. Whenever you are removing that thin epithelial layer, do you see proper skin underneath? I don't think so. You see some reddish tissue, or maybe sometimes bleeding starts again also, right? So what is that reddish tissue? That reddish tissue is actually going to be granulation tissue. So remember, granulation tissue formation is going to start when? It is going to start on day 3. Not only that, do you know the collagen formation is also going to start on day 3? So ma'am, day 3 is quite the important critical day, because everything starts here. Granulation tissue starts here, collagen starts here, but there's a problem. If collagen has started, then ma'am, scar must have formed. No, the collagen that starts is only at the margins. That is what you have to know. So if I take a blue color, this is where the collagen formation is going to start. It is going to start at the margin. So when does it actually complete? Remember, everything starts on day 3, whether it's granulation or whether it's collagen, but it is going to increase gradually. So if someone asks you, when does granulation tissue become maximum? It is going to be day 5. And if someone asks you, when does collagen become maximum? It is going to be day 21 or week 3. So remember, granulation tissue, collagen start at day 3, but granulation tissue is going to become maximum on day 5, and collagen is going to become maximum on day 21. Granulation tissue maximum day 5, collagen is going to become maximum on day 21. One more thing, if someone asks you, what does granulation tissue going to be? You know, granulation tissue is said to be the hallmark of repair. It is said to be the hallmark of repair. It is very, very red in color. Why? Because it has lots and lots of proliferating blood vessels. That is the reason that first we have that reddish color tissue when we peel off any blood clot, right? Hallmark of repair is granulation tissue. Now comes the next set of questions. If I ask you, what are the factors needed? What vitamin can be needed? Vitamin C and zinc is needed for wound healing. Next, what is the most common cause of delayed wound healing? Why is wound not healing? I know many of you must be thinking, ma'am, maybe patient is diabetic, that is why his wound is not healing. Maybe patient is a case of on steroids. Maybe patient is immunodeficient, but they've asked you most common cause, and most common cause is infection. As an intern, what are you told to do the most with the nurses and the interns? They keep changing the dressing every day, because if infection occurs, wound will never heal. Most common cause of delayed wound healing is infection. When does 100% wound strength come? Never. See, 70, 80, 85% wound strength comes back to normal, 100% never. Okay, now comes the next question. You have such a big wound, maybe someone had a road traffic accident and a big 10 centimeter wound happened, but gradually the wound will close. What do you think? This margin and this margin of the wound is closing. Which is the cell which is going to close it? So that cell, wound contraction, is caused by myofibroblast. Remember, wound contraction causes by myofibroblast. That kinds of tells me a logic. Don't write it, just understand. Myo means muscle, na? Contraction. It is a cell which can contract the wound. That is why I call it myofibroblast. Now comes a recent surgery exam question. You said that the collagen that starts is going to be on day 3 and the collagen that ends maximally is going to be on day 21. But do you know the type of collagen varies? In the starting that we have, it is going to be collagen type 3, and in the ending when we come, it changes into collagen type 1. Ma'am, why does it change like that? Because collagen type 1 is the strongest collagen, and I want that my ending, like skin, in the end what is formed? The scar and skin is formed. I want that type 1 is skin, right? So the strongest collagen should form in the end. But in the beginning, I make type 3. So the surgery question was that at the end, if they ask you the ratio, that can you tell me the ratio between the type 3 collagen and the type 1 collagen? So first tell me, in the end, what is more? Ma'am, in the end, the OG one, the strongest one is more. So the ratio is going to be 1:4. In case in the exam they ask you, tell me what is the ratio between collagen type 1 and 3, you always have to keep one more. So then your answer will become 4:1. So don't just learn up 1:4 and just go in the exam. Know the concept that in the end, type 1 collagen has to be more. So it is here, it is 1:4. If I reverse the numerator denominator, then your answer will become 4:1. So the logic is that in the end, type 1 strongest collagen has to become more, so that becomes more in the end. Finally, what if wound healing occurs more than required? I didn't require so much, but it occurred more. So the first one you will see, ma'am, patient got hurt and after that only red color tissue kept forming. Scar bana hi nahi, scar did not form. So that is known as what? That is known as proud flesh. You can see it's red in color. That is why they've called it proud flesh. And what is red in color? Granulation tissue. So proud flesh is nothing but excessive granulation tissue. Again, a genetic defect that can happen in people. Next, you will say, no, ma'am, what if it's not red color, it is excess scar that is forming. Either it's looking like this or it's looking like this. So there are two scars. Number one is known as keloid and the number two is known as the hypertrophic scar. So you will have to look at it clinically and find out. Can you see a keloid is looking more aggressive? Like imagine someone went for an ear piercing. Ma'am, ear piercing is hardly 1 mm. Tiny little needle prick that happens. And look at this healing. Look at the keloid. It has crossed all the margins. So keloid will look more aggressive. And hypertrophic scar means if it is just a single line, the scar has occurred somewhere around that. So which is more aggressive looking? Keloid is more aggressive looking. What is the most common site of a keloid? It is going to be the sternum. And what is the injection that you put in a keloid? You are going to give an intralesional injection. What is the intralesional injection means? I'm going to give an injection in the keloid. It's not some other route of injection. I give an intralesional injection of a drug that is known as triamcinolone. What is triamcinolone? It is nothing but a steroid. Okay, so remember these are the two questions. Most common site of keloid is sternum. Injection of triamcinolone is given. One question for INI-CT aspirants is that if you want to look at keloid and hypertrophic scar microscopically, what stain do you use? We use the Mason trichrome stain. Please note, not Mason Fontana. Mason Fontana was chapter 1 melanin. Fontana, tanning of skin was melanin. I'm talking about Mason trichrome. Trichrome tells me that there are three colors. Tricolor, three color. What are the colors? So remember there is a color called red. Then there is a color which is going to be blue. And then there's another color which is blackish, which I'm not interested. My concern is two colors out of these. Out of them, remember, Mr. Muscle is going to become red in color and obviously collagen becomes blue. Whenever you are confused between muscle banai or collagen, you will use Mason trichrome. So tell me, over here, both of these slides are looking very, very blue. So this is certain that collagen has formed. Which of them is keloid and which of them is hypertrophic scar? So if you look at the blue color fibers over here, you can see that they are all, some are arranged diagonally, some are arranged more diagonally, some are arranged vertically, horizontally, round. Ma'am, they are thick blue fibers and arranged everywhere. So whenever you see haphazard collagen bundles, that is a keloid. But when you see, ma'am, all of them are arranged in very thin, they are arranged all in one direction. Very thin, orderly fibers, that is hypertrophic scar. So way of learning is clinically also, which was looking more aggressive, keloid was looking more aggressive. Microscopically also, which is looking more aggressive, going here and there, that is keloid. Clinically, what was looking more orderly and straight and confined, hypertrophic scar. Microscopically also, what is looking orderly, straight, confined, hypertrophic scar. Remember the stain for differentiating muscle and collagen, it is Mason trichrome. On that note, we finish off our chapter of inflammation, the second most lengthy chapter of rapid revision. And of course, you are now ready to go on to the next chapter, that is genetics.